everyone. My name is Anila Hashmi, and I'm a medical lab and research scientist. In this talk, I will share the latest scientific facts and the limitations of the Rapid COVID-19 Antigen Test based on published data. Nowadays, COVID-19 Rapid Antigen Test is one of the topics discussed between the media and scientists worldwide. What scientific studies have revealed so far will be discussed in this presentation. COVID-19 outbreak has become a huge public health issue due to its rapid transmission and global pandemic. There is a massive amount of information available online on COVID-19. So how can you tell what is factual information and what is not? Make sure that the information is coming from an authoritative source on COVID-19. Trust your local authorities like local city or country health department to have the most accurate coronavirus information for your community. Timestamps and deadlines are also important in a rapidly changing situation. Check that the information is recently published. For scientists, one of the most reliable way of factual information is also to find the underlying peer-reviewed research and scientific articles on COVID-19. The ongoing pandemic COVID-19 is caused by severe acute respiratory syndrome coronavirus 2 that first appeared in Wuhan, China in late 2019. To date, due to rapid transmission globally, there are more than 4 million deaths have been reported. The COVID-19 unprecedented crisis led to a worldwide effort to rapidly characterize the immunobiology of SARS-CoV-2. Severe acute respiratory syndrome coronavirus 2 is the virus that causes COVID-19. SARS-CoV-2 is a single-stranded positive sense RNA virus. It has a genome size of 30 kilobases that encode for multiple structural proteins comprising the spike, the envelope, the membrane, and the nucleocapsid, as well as some non-structural proteins. Published data showed that SARS-CoV-2 mainly affects the respiratory tract, which can present as mild symptoms or progress into severe complications that can be fatal. For example, it may manifest as acute pulmonary infection, coagulation disorder, or gastrointestinal symptoms, most commonly diarrhea and nausea. Published data showed that SARS-CoV-2 is mainly transmitted via respiratory droplets and aerosols from an infected person when they sneeze, cough, speak, or breathe in the close proximity to other people. The virus has also been isolated from the feces of infected cases, indicating that fecal-oral transmission might also be a route of infection. Droplets can be inhaled or can land on surfaces that others come into contact with and are then infected when they touch their nose, mouth, or eyes. The virus can survive on surfaces from anything between a few hours to a number of days. However, the viable virus declines over time and it may not always be present in sufficient quantities to cause infection. The incubation period of COVID-19, that is, the time between exposure to the virus and the onset of symptoms, is currently estimated to be between 1 and 14 days, as per the published studies. Viral load in the upper respiratory tract peaks around the time of symptom onset. Viral shedding begins approximately 2 to 3 days prior to onset of symptoms. Up to 60% of transmission of SARS-CoV-2 may occur via pre-symptomatic carriers. By definition, asymptomatic case is a person with laboratory-confirmed SARS-CoV-2 who has not shown any clinical symptoms during a 14-day follow-up period since the last possible exposure to an index case. On the other hand, pre-symptomatic case, a person that is asymptomatic when testing positive SARS-CoV-2 but who develops COVID-19 compatible symptoms during the 7-day period after collecting the sample which tested positive. To highlight the role of asymptomatic and pre-symptomatic cases in the disease spread, a study in the Republic of Korea in March 2020 reported that 110 out of 303 patients with SARS-CoV-2 were asymptomatic during the period of isolation, and 21 of those developed symptoms during isolation. This study indicates that the viral RNA levels in asymptomatic cases are at the same levels as in symptomatic patients. Laboratory testing plays a critical role in defining the disease characteristics and epidemiology of an emerging infectious pathogen, such as SARS-CoV-2, and controlling its spread. Currently, there are two types of COVID-19 tests that are designed to detect whether the person is currently infectious: PCR and antigen test. Both work differently. While antigen tests detect proteins, also called antigens, on the surface of the virus, PCR tests detect genetic material called RNA that instructs the virus to make these proteins. Both tests also require a swab from the back of your nose or throat. In the case of PCR, the sample is sent to a lab where RNA extracted and converted to DNA. PCR amplifies DNA using reagent and PCR machines where it is heated and cooled and then make millions of copies of the DNA, which allows for the identification of the organism. This process can take hours, requires sophisticated lab equipment and technicians. Although the sample needs to be sent to the lab, the time-consuming process delivers as the result are almost 100% accurate in spotting infected people when there is a virus on the swab. In contrast, most antigen rapid detection tests for COVID-19 use a sandwich immunodetection method employing a simple-to-use lateral flow test format. It works by mixing the sample with a solution that unleashes specific viral proteins. That combination is then applied to a paper strip that contains a bespoke antibody optimized to bind these proteins if they are present. Like a home pregnancy test, the result is reflected as a band on the paper strip. The process doesn't require a lab and can be done in up to 30 minutes, but that speed comes at the cost of sensitivity. Although these tests are reliable when an individual has a high viral load, they are far more prone to false negative results if a person has low amounts of the virus in their body. Because these rapid antigen tests don't amplify what's in the sample, so can detect the virus only when it reaches a high level in person's body, with perhaps hundreds of thousands or millions of viral copies per milliliter of sample. The viral usually reaches these levels around the time that symptoms start, when people are at their most contagious state. Without analytical accuracy of these rapid antigen tests, there is also no diagnostic accuracy and reliability. Lateral flow immunoassay is a qualitative point of care method that combines the principles of thin layer chromatography and indirect immunochemical sandwich method with two antibodies, that is, binding and detection antibodies. When a sample is applied to the pad, the analyte forms an immune complex with a detection antibody. The sample moves laterally and forms a sandwich with the binding antibody. After a period of time, a colored line forms at the site of the equivalent zone. The appearance of colored line indicates the presence of a target analyte in the sample, and in this case, SARS-CoV-2 antigen. Tests from different manufacturers have different test performance and therefore different reading times. Most of the tests return results after 15 minutes. There is a negative result occurs if the amount of antigen in a specimen is below the limit of detection of the test. So the limit of detection of a method can be defined as the smallest amount of a substance that can be detected with reasonable certainty by a given analytical procedure. Manufacturer declares a cutoff value leading to possible interferences. Interference can be defined as the effect of substances present in an analytical system that cause deviation of the measured value from the true value. Some possibilities of false negative results due to analytical interferences are a high dose hook effect that may occur if the tested sample contains a high concentration of SARS-CoV-2 virus. Biotin interference can also lead to false negative result if present in high concentration in patient sample. Also, the cross-reactivity of other viruses and other substances also lead to false negative results if present in more than cutoff value. Antigen rapid detection test performance is determined by the sensitivity and specificity of the test to detect SARS-CoV-2 infection compared to a PCR reference standard test. In journals, sensitivity and specificity describe the accuracy of a test. For SARS-CoV-2 rapid antigen detection test, sensitivity is the percentage of positive cases by PCR tests that are also detected as positive by the antigen rapid detection test. And specificity is the percentage of negative cases by PCR reference tests that are also detected as negative by the antigen rapid detection test. An alternative way to report test accuracy is using positive and negative predictive values. So predictive values measure the number of positive index test results that will be true positive and the number of negative index test results that will be true negative. The nearer the positive and negative predictive values are to 100%, the better the test. So the prevalence of disease in the community being tested strongly affects the test predictive value. This is particularly important given the dynamic and heterogeneous epidemiology of SARS-CoV-2. WHO has defined minimum performance criteria for antigen rapid detection test. That is, SARS-CoV-2 antigen rapid detection test must meet the minimum performance requirement of more than 80% sensitivity and more than 97% specificity compared to an approved nucleic acid amplification test or NAT molecular test, for example, PCR. This slide shows the sensitivity of rapid antigen test when compared with the gold standard PCR test. The graph shows the level of SARS-CoV-2 viral load over time from 2 days prior to symptom onset to 20 days post-symptom onset. It shows the cutoff values, that is the minimum viral load necessary for the infection to be detected by PCR and antigen rapid detection test. As you can see from the graph that antigen rapid detection tests are less sensitive. In other words, they require a higher viral load to be present for the test to be positive. So this another graph shows the area with blue stripes between the respective cutoffs of PCR and antigen rapid detection test, which represent cases that could be missed if only a SARS-CoV-2 antigen rapid detection test is performed. My teenage daughter recently had COVID-19. Due to her interest in science and medicine, she decided to compare her symptom profile with her rapid antigen and PCR test results. She kindly allowed me to share the image. You can see the rapid antigen test results were still negative until 4 days into her symptoms. A day after the positive PCR test she took on day 3, after she first exhibited one of the main COVID-19 symptoms, that is high temperature. Lessons are: be aware of the false sense of security a negative rapid antigen test can provide. If you have COVID-19 symptom, get a PCR test. The main COVID symptom might not always be present and certainly not at the start. I shared this image with the permission of my friend, and now, in the next part of my presentation, I will share what scientific studies have revealed so far on this topic. As scientific data matters, to control this SARS-CoV-2 infection. This peer-reviewed research article published in July 2021, they compared the analytical sensitivity and specificity of 7 commercially available antigen point-of-care test devices. Tests were evaluated on stored respiratory sample with known SARS-CoV-2 viral loads. They estimated the analytical sensitivity in terms of approximate viral concentration, quantified by real-time PCR that yielded positive antigen point-of-care test results. As you can see, in terms of specificity, 5 out of 7 tests fulfill the WHO minimum performance criteria, that is more than 97% specificity. In terms of sensitivity, as you can see in this image, when viral concentration is high, most of the test results showed blue color, which is true positive. However, when the virus concentration medium or low, then most of the test result shows red color, which is false negative. What this means? That the sensitivity range of most antigen point-of-care tests overlap with SARS-CoV-2 viral loads typically observed in the first week of symptom, which marks the infectious period in most patients. So this study concluded that most of these assays could potentially be used in efforts to limit transmission, but due to their lower sensitivity than RT-PCR, antigen point-of-care test might not have the power to exclude SARS-CoV-2 infection in the very early and later phases of COVID-19. In addition, screening of asymptomatic patients with the expectation of being able to discern between virus absence and asymptomatic or pre-symptomatic infection is more difficult. This research study published in April 2021, they evaluated a rapid antigen pan-bio COVID-19 test for SARS-CoV-2 detection in asymptomatic close contacts of COVID-19 patients. A total of 79 out of 634 asymptomatic individuals tested positive by RT-PCR, of whom 38 returned positive by rapid antigen detection test. As you can see, the red circle shows the number of false negative results when compared with RT-PCR, and the blue circle shows the number of true positive results reported by antigen rapid detection test when compared with RT-PCR. So you can see here that the SARS-CoV-2 RNA load was significantly higher in rapid antigen test positive patients than in rapid antigen test false negative individuals. Also, the sensitivity was higher in household than in non-household contacts, as you can see in this chart. So the overall sensitivity of pan-bio COVID-19 antigen rapid test in asymptomatic close contacts was 48%, and the specificity was 100%. Following the emergence of COVID-19, there has been prolific industry activity to develop accurate tests. So the Foundation for Innovative New Diagnostics, FIND, is a WHO collaborating center for laboratory strengthening and diagnostics technology evaluation. So FIND is collating an overview of SARS-CoV-2 tests that are commercially available or in development for the diagnosis of COVID-19. They have compiled a fully searchable directory for immunoassay and molecular tests. Manufacturer performance data and data from independent evaluations conducted by FIND are also included. So as of August, there are 165 immunoassay antigens that are commercially available for the diagnosis of COVID-19, according to FIND. So now I share the Cochrane review on how accurate SARS-CoV-2 rapid antigen tests are. So firstly, Cochrane is a global independent network that gathers and summarizes the best evidence from research to help informed health decision making. So in their review, they included 64 studies Only 3 studies were exclusively in people without symptoms. Investigated a total of 24,087 nose or throat samples. So, studies investigated 16 different antigen tests and 5 different molecular tests. In terms of test sensitivity, in people with confirmed COVID-19, antigen tests correctly identified COVID-19 infection in an average of 72% of people with symptoms, compared to 58% of people without symptoms. In terms of specificity, people who do not have COVID-19 antigen tests correctly ruled out infection in 99.5% of people with symptoms and 98.9% of people without symptoms. This updated systematic review was published in March 2021, and they summarized that rapid antigen detection tests were most accurate when used in the first week after symptoms first developed. This is likely to be because people have the most virus in their system in the first days after they are infected. There are large differences in the accuracy of different brands of tests, with very few meeting the World Health Organization minimum acceptable performance standards. However, these tests do not appear to perform as well in people who don't have symptoms of COVID-19. Moreover, they didn't find any data or studies evaluating the accuracy of these rapid antigen detection tests when used in repeated screening of people with no known exposure to SARS-CoV-2. These testing policies have been implemented without any supporting real-world evidence. Worldwide, current testing strategies are flexible and rapidly adaptable to change, depending on the local epidemiology, transmission, population dynamics, and resources. Science tells us what we can do. Guidelines tell us what we should do. Follow your local health department guidelines to control this pandemic. Thank you.